Parkinson's Wellness Project is here to help. We have an exercise program, a workout program for men and for women. We teach rock steady boxing, we have a dance class, and we have a PD on the Move with Alex Tresser. All of our classes are over Zoom. And you know, Alan knows, Gloria knows, a lot of people here take our exercise classes, that it's key, and we have to keep moving. The other thing, I just want to tell you about two things that we're doing in the fall. One is called a Neuro-Mindful Workshop. And what that is, we're working with Dr. Sarah Mulakulta, who's a neurologist and has been doing a lot of science-based work on relaxation and meditation. It's a 6-week workshop, 3 in September, 3 in October. The only thing is one is in person and you have to show up to that one in Pomona, New York in September and one in November. Yes, do you have a question, Robin? It's free. Yeah, we try and do free things. That's why we get supported by our wonderful pharmaceutical companies. And then one other thing for women only, we'll do this for men maybe in the future, but for women only, we're having a music, movement, and medicine event on September 11th, and we want all women to come to that. It's going to be wonderful with Chechi's dancing, we have a music therapist, and we have Dr. Parahar, who does something called Brenga dancing. I bet you don't know what Brenga dancing is. Brenga dancing is like Indian hip hop. You have to look it up on YouTube. It's awesome. And she's going to be teaching us that. And Chechi's a beautiful modern dancer. We're going to be doing a lot of beautiful things. So save September 11th. I know we have the whole summer ahead of us. So right now, I think I'm going to introduce the doctors because it's time to get started. I think, are you almost ready with, I'll introduce you while you're doing all this. So this is the last in our series of Discover Your Healthcare System. And I think you'll see when we work with our doctors here, this is going to be a little bit more interactive. We're going to work with Dr. Harold Shaw. She's an assistant professor of neurology at Columbia University Medical Center. And in the division of multi-specialty neurology, she completed her undergraduate at MIT and her medical doctorate at Indiana University. She completed her neurology residency at Columbia, serving as the chief resident in her final year. She is currently a global mental health scholar and also serves as coordinator for WHO's project on dementia. And I know that Dr. Shaw is going to talk about the book that she's working on and also, so we'll get that up. Yeah. Also, after Dr. Shaw, Dr. O'Shea will be speaking to us. She sees patients with low movement disorders, and she specializes in deep brain stimulation, and also is doing some special research on weight in DBS, and she's going to be talking to us about that. And Dr. Julian Agan, we will meet, is an assistant professor of neurology in the Movement Disorders Division. He completed his medical degree at the Medical School of International Health at Ben Gurion University in Israel. He is going to be talking to us a lot about genetics, and I look forward to you enjoying and learning a lot. But I want to say one more thing. We get together to be together. And we don't want to live in an isolated world. We want to stay connected. And it's those connections that we make with each other, what we learn from each other, how we help each other. And I think at a time like this, when the world is so crazy and we're coming out of being isolated, we have to get back to being together and helping each other and giving to each other. So I see my good friends here, and I'd like to have all the doctors come sit here.
You have notes or here. So the way you just do that in student is. Oh. You have to stop sharing or.
You can share.
Oh, it says it won't let us. It's not allowing. It's like you have to do the partial screen share that allows you to be really advanced. So you can like cut off. Very well, because you're Can you hear me? Oh. Good evening. Can you hear me? Yeah. Okay. Hi, good evening to everyone that's here and those that are meeting us virtually. Hello to you. This is kind of nice that we can connect in person finally, as well as virtually. And I wanted to echo some of Sue's, a little louder. Okay, hold on. Let me. All right. How's that? Okay. Thank you for letting me know. Well, again, I was just going to say, I wanted to echo the sentiments of Susan's that I think we're here to connect and be together. And so I hope this talk gives us an opportunity to think through that lens. As Susan said, I wanted to share with you all a project that I've been working on since about 2019. And it's a book called The PD Movers. And I'm hoping to share with you all some of the lessons that I've learned about the power of storytelling and how that can foster resilience, build community, and empower individuals. And I'm hoping that we'll have a chance to interact a little bit at the end of my talk. My talk is going to be pretty brief. I just want to describe and share this resource with you, but more talk about how it could empower you and impact your local community. And as I was coming here, I was listening to a podcast, and it reminded me that, you know, whenever we use these words like community or resilience, empowerment, we all may have different definitions of what that means. For me, community means an experience that we have a shared experience. You know, I know Sarah and Julian, and we have a shared experience of working at Columbia, and I have my Columbia community. And then I might have the community of my daughter and her nursery school. So we all have different communities, and each of those communities may have different needs. And I think each of us has an individual story and a voice that deserves to be heard, and a story that deserves to be seen. So I hope that that will connect with you and we can touch on that a bit more. So first of all, who are the PD movers? So what led to this work was, you know, as you may be aware, Columbia University Medical Center is situated in Washington Heights, Inwood. That sits within a very multicultural community, predominantly Hispanic, many individuals hailing from the Dominican Republic. And throughout my training and as a faculty member, I observed that sometimes the diversity of our community was not reflected in our waiting rooms. So I wondered what was the root cause of that and what might be something that we could do at Columbia to help foster more sense of community and connection with our immediate geographic community. So I participated in a course called Community-Based Participatory Research. And the principles to me are quite simple. The idea that recognizing that there often are power dynamics when it comes to physician-patient or physician-community relationships, And that if you really want to affect change and create behavior change in a community, you need to start from within. Meaning you have to partner with members, understand what are their needs, what are their values, what are their priorities. And that when you partner with someone, have a true partnership, I think we know that that partnership has to be equal. There can't be someone who's in charge and someone who's following along. So I really sought to instill these principles in everything that I do and began to work with St. Luke AME Church to better understand the community of Washington Heights, Inwood, and the surrounding areas. And one of my partners at the church was Miss Anita Parker, outreach director and social worker by training, and she'd been working in this community for 40 years. So she really understood the needs of her community and what their priorities and values were. And what she taught me is that, Hero, if you start talking about Parkinson's disease in Harlem, nobody is going to come. You have to talk about brain health. She explained that people at her church and her community were not comfortable talking about Parkinson's disease. They didn't feel that they could speak openly about their diagnosis. Family members often faced a lot of secrecy and isolation. And I have to be very honest and vulnerable with you, is that I know the same is true in my community. I'm a child of Indian immigrants, and I know in the Indian community there are a lot of cultural norms or norms about what we talk about and what we don't talk about, what we keep at home and what we share with other people. So I could understand and relate to how this was happening and how that impacted someone's ability to seek care. So in 2019, we began to have brain health seminars, just trying to educate people about what are the principles of brain health. And over time, people began to be more and more curious because naturally people want to, as you do, learn about how they can improve their health. I think that is a fundamental feature of being empowered, is being curious and being willing to ask questions and learn more. So over time, people began to understand, like, well, what is Parkinson's? What can we do? And so Ms. Parker said, I think we're ready. We want to develop a resource about Parkinson's disease. And because we had spent so much time in the church, and I observed that in church, people naturally delivered testimony. They would speak about an experience, an obstacle, an opportunity, an episode of hope, and they would share that with the congregation, and the community would kind of come together to uplift that person that might be going through a difficult moment. So I thought, well, why don't we use storytelling, which echoes testimony, and combine it with educational materials and put together an educational resource? So that's what we did. And I'm so proud of what we've put together. And I just want to show you some examples and then tell you about some of the impacts of this work. So the book starts out with this image of a group of individuals declaring that, we have Parkinson's disease or care for someone with it. We made sure to include the care partners. We know how critical they are and how important it is that their voice be heard. We face challenges from diagnosis to living with the disease each day, but we have learned to live and thrive. Oops. Sorry. We then feature the voice of the person living with Parkinson's, but highlight who they were before Parkinson's. So often we become focused on the disease, the symptoms, the impacts it has, but everyone with any condition was a human being, was a person with interests and history and background, and it's so important to remind people of this human aspect, and that doesn't go away regardless of your diagnosis. So this is Don Ransom, who highlights how he was a musician, played the trombone, tuba, and sousaphone. He was a certified electrician. He was in the Air Force. He had many different hats as a mail carrier, playing sports. And so just reminding people of who the person is, not just was. Sorry, I'm technologically challenged today. Then we highlighted some experiences of recognizing the first symptoms. And I'm sure many people in this room could relate that often the first symptoms of Parkinson's in retrospect may have come many years before one was diagnosed and often are dismissed or thought to be representing normal aging, or we just don't know what's happening. And that can create a lot of anxiety and turmoil. Just to show that that experience is quite universal, many people go through that. Then we wanted to show an example of what it's like to have a diagnosis, that what does it mean? What is Parkinson's disease, so that people could understand, and what it looks like to be diagnosed for those that have never maybe seen a neurologist or specialist. We touch on some of the myths and facts of Parkinson's disease, the fact that some people think that it's a death sentence or that there's nothing that can be done, that there's no treatments available. And then we outline what treatment looks like. How treatment, I think you all know because you're here, that it extends much beyond seeing your doctor in the doctor's office, but community events like this, learning more, exercise, wellness, nutrition, and how all of these aspects combined make up what treatment looks like for Parkinson's disease. And I know you can't really quite read this, but it's just to give you an idea of what's in the book. And then finally, we touch on the importance of faith, family, nutrition, and exercise. So these are just some examples to give you a little snapshot or taste of what the book looks like. And you can imagine that what I hear after we develop this book is that each community needs a book like this, because all of our communities are very different, have different priorities, different values. And I think that if we can each better understand our communities, as well as if healthcare professionals, even researchers better understand our communities, that perhaps they can develop treatments and strategies that are more tailored. You know, I know that many industries and academic centers develop research protocols and treatments, and then it turns out it's just not that great of a fit. But I think that if we better understood our communities, that might be able to change. Yes, please, sir.
Wait, hold on. Robin.
Give her a minute.
So, yeah, I in my former business life, I worked with all kinds of people, and I got close to them, and sometimes they'll call me and say, "I just found out my mother had Parkinson's," and they say, "What should I do? What should I read?" And I always point them to a book called The Parkinson's Primer.
Mhm.
Are you aware of The Parkinson's Primer?
Actually, I'm not. You guys have read it?
It was written by a guy at Covington and Burling who ran their H&R practice. It's a great book. I was just wondering, is there a successor book that you could recommend? It's a little old, but it goes to the issue you have of like, how do you introduce this disease to the family, you know?
Mhm.
Like from a public health point of view, you know?
There are a number of resources, and I'll also ask Sarah and Julian for their thoughts. So for instance, there's a gentleman who is collecting these types of resources on a website called The Quiver. So he has compiled a list of books that people with Parkinson's have written, but it also includes like reference books like what you're talking about. I think just like you said, everyone maybe needs a different dose of what they want to learn and how much. There can be an overwhelming amount of information. So, but I think the Quiver might be one place to start. And I would also suggest looking at the major Parkinson's organizations like, you know, Parkinson's Foundation, APDA, Davis Finney, like the Victory.
What they're focused on, you know?
Right.
I mean, it's really the tail end of the animal, and a lot of times the stuff is not accurate or fully complete. Or it's so, yeah. I was just curious what because you're looking at a community and people come in and they have different needs. I'm looking for that next book. I mean, I thought the Parkinson's Primer is wonderful, but it's probably like 15 years old, you know?
Maybe I'd happy to chat with you more about what it is that you're looking for, because then maybe we can try to help identify what type of resource, because I think you're right. There's resources for patients, for caregivers, for families, focused on the disease, focused on living, focused on treatment.
You could go online and put in Parkinson's Primer, you'll see the book.
Yep. I'll take a look.
Do you know the book Parkinson's for Dummies? Do you know that one?
I was gonna say the Michael Oken, Bastian Blom book, and I'm blanking on the title. I'm so
Parkinsons.
ending Parkinson. Yeah, I think that's very patient centered, and I don't know. I recommend that one for my patients. Ending Parkinson's by Michael Oken, and I think Bastian Blom's on that too, right?
Mhm.
That's Ray Dorsey's book, right, with
Yeah.
Oaken,
Yep.
and yes, and we have a copy of it over on the table here. That deals with a lot of toxic
The environmental.
environmental
The
situations.
Parkinson's epidemic.
So yeah, I just wanted to highlight how this type of book has for the participants, it's created opportunities for emotional empowerment. Many of the people involved in the book that have started to share their stories are now advocates, speaking up for their community. There are people in the book who had previously never shared that they had Parkinson's even with their siblings. And so for the first time, they had a conversation over Thanksgiving saying, I never knew this was what you were dealing with. It's opening doors to churches and support groups who are curious to learn more. So part of my goal today was just to remind you all that each of you has a voice and a story that you can share, whether it be sharing an experience you had, just as you did, about someone asking you about, like, what's a book or a resource? It might be in the grocery store. I remember a Parkinson's advocate said to me that she noticed that people in the grocery line were kind of seeming impatient, and she just took a moment to say, I'm sorry, I have Parkinson's. And she saw immediately the body language shifted, and people were very understanding and willing to kind of be more patient and help her out. So using your voice doesn't mean you have to write a book, doesn't mean you have to get up on a stage and speak, but it could be in everyday occasions. And the other thing I'll remind you is that for each person that's here, there are many people that are at home that don't feel comfortable coming to events like this or have competing demands. And so you are a voice for those people in your community that might not be able to attend events like this. So you could be a voice of encouragement. You could be a voice of communicating resources and sharing resources as you did. But I would just encourage you to share your story. And if you all will humor us, we thought we might do a little exercise to do this. We're just going to take a few minutes of your time. There's a few rules, just that one person at each table, and maybe if there's a couple tables with less people, we can combine. But one person speaks at a time, trying to be honest and open, but also only sharing what you're comfortable with. Recognizing that this is a safe space. No one is going to be recording what you share or taking it elsewhere or using it for any purpose. And that I would just ask every person, if you're comfortable, taking 2 to 3 minutes just to share a personal story about your journey with Parkinson's, whether it be a challenge that you overcame, a moment of hope, an experience that you had, maybe when you were diagnosed, or even earlier today. It could even just be how you're responding to what I'm telling you. Maybe you don't like it. Maybe you think it's a good idea. But even that would be a wonderful opportunity to share. And I would just encourage everyone else at the table to try to listen actively. Have an opportunity to reflect and respond to how listening to someone's story might have made you feel. Because you might be surprised how your story impacts someone else. Yeah, go ahead, sir.
So I was diagnosed at Columbia. And the thing that was most remarkable to me, I saw Dr. Oren Levy. He was wonderful. But I walked into the waiting room, and it was the equivalent in my mind of these. You see the diagram, the stages of man. It was the stages of man of Parkinson's, and I have to say it was frightening. And I've talked to other people as well about that experience of seeing all the different stages. And it occurred to me that it might be helpful to.
We're going to change that picture, right?
Yeah.
We're going to stand up tall, not bend over, and we're going to grow taller. But I think, Robin, what we're going to do is everybody's going to have a chance at their table to tell their own story.
Yeah.
So what we're going to do, Dr. Shaw, is give everybody 2 minutes at their own table to talk. So everybody hover around your own table.
right? And if you don't feel comfortable sharing your story, you can jot something down. And then as a group, I hope we'll come together just for a few minutes to touch on what that experience felt like for you. And I can just say in reaction, what it felt like for me to hear your story is, I think I hear that a lot, that people are worried about the future. They're afraid of what's to come. And I think that's very natural. And I think that for some people, they face that and say, you know, I'm going to keep going, or I'm going to go to that exercise class, even if I see other people that are at a different stage of their disease, and I'm going to get a lot of out of it. And then there are those who say that's not for me. And I think sometimes to their own detriment may become isolated. So I think that if we're open about our fears, that other people might, first of all, meet you where you are and say, you know, I felt the same way too, and this is how I overcame it.
Right, what was sit over there with Solange's sister?
Yeah, no, but I can envision what you're experiencing. I have a picture in my mind of what that might have felt like.
What are you using?
Okay, so we're gonna take a few minutes for you to share.
We timing the 2 minutes?
If you said that you might be able to time, or do you want me to time?
Yeah. No,
Okay,
we
I
could
can
time.
time also. I have a trusty timer.
Royce, could you put the timer on? And we'll,
Gonna dig and one.
are you ready to start?
Yeah, I think so. Go ahead. So the first person in.
One person sharing a story at the table.
I thought I had essential drugs. And I decided that I needed to about 2 years ago, they said to me, you think it would be Parkinson's, but I that. And so I believe I think maybe that was back so that's and the exercise. I'm on my own. And next is a picture. So I can't go to the cancer. And I've been very fortunate. Friend, started the exercise with me. It's a wonderful people. And I play cards there once a week. And I go to the exercise, but I'm very busy. And I don't.
You know, you don't look that you have positive, to be honest with you. It doesn't seem that you have nothing. You're doing a great job, that's what I was doing. Because I have said before, I do have Parkinson's, I was also diagnosed. And I really told me that I have essentially friendliness and stuff. But I do the same family, basically. Only on one side.
Absolutely. Yeah, listening is just as important.
No.
Next person.
Yeah, so if someone's finished sharing, if we could make sure that everyone else at the table has, or whoever's willing, I don't know if everyone wants to, but move on to someone else sharing their story. But I see a lot of conversations happening, so I think some sharing is happening. Oh yeah, and please remember, active listening. Active listening is so critical. That's the other half of storytelling.
All right, starting in next 2 minutes. So I'm trying to think of something here. The election I found
Try
that
to listen.
the times when I take my grandchildren.
Yeah.
Nothing was needed for you. I found you have to be engaged. Not gonna be full. I found. There's gotta be another way to do the same thing. I got to pick this up. So I had to get. It's not, I'm just hooked it up and I paid it. A lot of emotion. Back. I think.
You feeling child, they call it. So like just they say you're deeply feeling.
What is it good for?
It really wants to I tried it.
I'm gonna write a book on what.
Like my problem is consistency, because I'm really consistent. All of these.
They know, like, we get away with whatever, them. So, but you feel like when they're around here, then she comes back and like, it's absolutely, and you have to like,
Yeah, I don't think it was sitting like yes.
I'm not the most disappointed, like, in life.
The history shows it, but the history shows it. That's not a very good piece of it. I have to. That's a very, very bad shape. Yes. There's no choice.
Looks like everyone has had a chance to share. Do we have a microphone just to take around? Would that be all right? So if anyone is willing to share, you know, how did it feel to share your story, or how did it feel to hear a story that might have resonated with you? Anyone willing to?
All right, I'll start. What I was just saying to my table mates is that, sure, when I found out I had the diagnosis, it was devastating. It's devastating for everyone, but I feel so fortunate that I did some research and I found doctors and therapists, physical therapists, my Simona, great chiropractor who takes care of my body, learned about nutrition, and just do everything I can, sleep well within my power to stay calm and appreciative of all the little things. And onward we go.
That's beautiful. Thank you so much for sharing that.
That's great.
Is there anyone else that's?
I could share something.
Yeah.
I was just telling with at our table that I found very helpful is that when you get stuck with something you don't know what to do with because my hands don't work, my foot doesn't work. I've been stuck in some very embarrassing situations where I'm stuck and there's nobody there. What am I going to do? And I calm myself down. I've said, I have to be incredibly creative. How else can I do what I expect to do? I got stuck with a dress on at the late night evening. Everybody else had gone to sleep already, and I couldn't get the zipper undone by myself. I'm standing there. I don't want to sleep in my dress, but everybody else had already gone to bed. So I took a yarn and I took a safety pin, and I put it through the eye of the zipper, and so the yarn hung down. I was able to pull it down and get out of it
Very
myself.
smart.
No, it was desperate.
Creative.
Desperation. But I learned from that when I get stuck in situations, if I take some time, I may be able to look outside the box and be able to resolve it.
That's a great story. Thank you so much for sharing.
That's great. Okay. Who wants to tell a story here? Naomi? Is that Naomi?
I think it's my friend to the left.
Hi.
Whoa. So I got to hear a story at this table that kind of felt sad to me about the difficulty of some neurologists in actually relating to their patients as people in a moment, as opposed to, a diagnosis. So Yeah, that kind of speaks to something that I would have spoken to also, is to like, once somebody has identified that Parkinson's is a part of their picture, there is also so much else that's happening
Mhm.
with that person. So I hope that there can be some training, you know, for physicians and, you know, all the people that take care of people to not get too caught up in the medical piece and remember the human piece.
Absolutely. And that's a message that we've been hearing too. So thank you for making that comment.
Oh, okay, Carol?
I got one that's a little unusual. My left shoulder and my left hand doesn't work very well. And I go into Dr. Pullman at Columbia and have my shoulder Botoxed, and it's helping me to go ahead. And the funny thing was, when I was first given the appointment with Dr. Pullman, I'm like, wait a minute, that's the doctor that diagnosed me with dystonia back like 15 years ago. He was still there. So it was really nice to go in, and it was a doctor I already knew. And that was like a little bit of hope, because it's very hard, but that might be an option for some people.
Yeah, no, I think feeling comfortable with your doctor is important. And yeah, Dr. Pullman's been there for 25, 30 years.
The building, I think.
So, yeah.
Came with the building.
Well, thank you all so much for sharing. I hope it was just a little taste of, you know, what it might be like if you're willing to be vulnerable and open up. And just again, I just want to remind you that for those that are here, there's so many that aren't here. So please remember to use your voice, share your stories within your communities. And I think you'll be hearing that common thread of empowerment through the rest of the lectures, that we're talking about deep brain stimulation, which is an advanced therapy. We all want to know about what's the latest and greatest. And Dr. Agan is going to be sharing some information about genetics, but it's always about you, the individual, the family, the community, and what all of this is doing to empower yourself and how it will lead to a better future for yourselves and your community. So thank you again for entertaining this activity, and
Thank you so much, Dr. Shaw. That was wonderful. I think we do want to write our own story, so you'll have to guide us.
absolutely would love to. Okay. Maybe I'll.
You want to go? Sure. Or you want us to? Oh, no, it's okay.
Hi, everyone. Can you hear me okay? All right, so I'm going to put my slides up. All right, here we go. I think we're in business now. So I'll be talking about advanced therapeutics for Parkinson's disease. And truth be told, I'm a deep brain stimulation neurologist that specializes primarily in Parkinson's disease and some essential tremor. But I promised Susan I'll be talking about some more advanced therapies beyond DBS. And I think those are just as important to talk about. And so what I'll be focusing on today is, first of all, well, what is an advanced therapeutic? And then secondly, more importantly, when do you know it's time for you to pursue those therapies, and how do you express that to your providers? I think this is a really important lesson that we need to know about, and also learn as even neurologists when to approach that, when the right time is to approach it, when the wrong time is to approach it, and if it's the right time, what should you do to advocate for yourself? So that's what I'll be focusing on for this presentation, and some of the background. So we all know what Parkinson's disease is. You know, we have the motor features, the stiffness, the slowness or the bradykinesia, and the rigidity, and also the postural instability. So you have all of these features of the motor parts of Parkinson's disease, but there's also some non-motor aspects of Parkinson's disease. And the reason I'm differentiating these two is because we really want to make sure we acknowledge what we can treat with advanced therapeutics and what we cannot treat. And I think it's really important to emphasize to patients that motor symptoms are the most adequately treated by these therapies and that non-motor symptoms are not. And that's why I really wanted to break that down and drive that home. With that being said, I think it's important to know that DBS and other advanced therapeutics could certainly treat motor symptoms very adequately, and that could be, the tremors that are throughout your body, stiffness, sometimes the stooping, but not always, and the flexion of your arms, and the tremor, of course, of the hands. Non-motor symptoms, what are those? That could range from the early prodromal symptoms, the hyposmia, the low sense of smell, fatigue, insomnia, REM sleep behavior disorder, which just like hyposmia could predate Parkinson's disease by, a decade or more. And of course, the autonomic features, constipation, urinary symptoms, dysautonomia in the sense of blood pressure fluctuations as well, sitting to standing blood pressure drops, and of course, cognitive dysfunction and mood disorders too. Loss of facial expression is listed there. That's technically a motor feature. I won't get into it, but it's always listed. It's part of all the captions that I use, or the images I use. So with that in mind, when we treat Parkinson's disease, we are treating that stiffness, slowness, that the postural issues, et cetera. But, really the medications are focused on stiffness, slowness, and tremor, right? So we have here the ons and offs that we're all very familiar with. So, on is when the medications, particularly carbidopa, levodopa, are working well. You're feeling great. All those motor symptoms melt away, and this is fantastic, good quality of life. But the off period is, of course, when those medications wear off. And as you can see here on the right, as the disease marches forward, you have these ons and offs, these motor fluctuations. That's what motor fluctuations are. Those periods of good on time start to narrow. Those become less and less, and then the off times become more profound, more significant and bothersome. And also you develop these dyskinesias. Not everyone develops them, but many people do. Those dance-like movements that are, non-rhythmic. They're a consequence of levodopa exposure in a patient with Parkinson's disease. So that's a motor complication. So that's what we mean by motor complications, dyskinesias and motor fluctuations. And those are the things we like to target in these advanced therapeutics. So when do we consider DBS in any advanced therapeutic for that reason? Those medications start to wear off too quickly. You have a good on, but it lasts only a few hours. And then very quickly, you're back to square one. Stiffness, slowness, tremor comes back, and it's very bothersome. And like I said before, that window becomes narrower and narrower, and that off time becomes more significant. So the medications wear off too quickly. It goes from 3 times a day dosing to, sometimes I've seen up to every hour on the hour you're taking carbidopa, but you're chasing these motor symptoms. The new movements, like I mentioned before, the dyskinesias, and then also medication intolerance. This is something that does come up quite a bit. You can't tolerate carbidopa, levodopa, or dopamine agonists like Pwp or Mirapex for one reason or another. Sometimes a severe orthostatic hypotension. You take the pill, great motor response, but unfortunately your blood pressure tanks, especially when you stand up. That's orthostatic hypotension. And then also, nausea. Nausea could be a very significant symptom for our patients with Parkinson's. 20% of patients, in fact, develop nausea on carbidopa, levodopa. In fact, Sinemet is Latin for don't vomit. And, that's where carbidopa is added on to prevent that side effect, amongst other side effects. But, the fact that it exists means that some people could just not tolerate it, no matter how much carbidopa or extra carbidopa you add to that Sinemet. So these are all reasons to consider advanced therapeutics, and DBS is the one that I'll be talking about next. So any questions about that before I move on? I just wanted to make sure that this was as open of a discussion as possible. Any questions about that as a concept? No? Okay. So deep brain stimulation.
Do you want to ask about Mirapex?
Oh.
Did you want to ask about Mirapex?
No, not anymore.
Okay.
Oh. Okay. Well, feel free if you want to. Just gonna.
I've noticed in the last 6 months that I'm having problems with what I call time dilation. my sense of time is beginning to change. I've looked at the literature and there seems to be a disagreement as to it's measurable at like milliseconds, but I just feel like time is beginning to slip through my hands.
It's interesting.
And, there's a big literature on it, that. So the question is, has anyone ever come to you and said something similar?
Yeah, actually. I mean, it's just that things do, the length of time that it takes to complete activities of daily living and even the most mundane things could take a longer period of time, and time is kind of stretched. It's kind of a vacuum.
But the thing is,
Perception.
the thing is, that's what's so funny. You feel like it's just like everything else in Parkinson's.
Yeah.
You feel like it's the same amount of time.
And sometimes I think it's a bit of an element of what we call bradyphrenia, like the slow thinking too that comes with Parkinson's. And some patients, even though it's purely a non-motor symptom, some patients swear that, I don't know if you guys can speak, but the levodopa affects that. I've found that quite a bit actually. So it's definitely non-motor, but then sometimes they find that medication is affected too, which is kind of interesting.
Thank you.
Yeah.
I have a question from the remote section. Hello,
Oh,
I have a
By the way.
question for remote.
how do I?
Can
Okay, you can go ahead.
hear me? I
You go ahead.
I was diagnosed in 2017. I'm having recently, within the last year, serious breathing issues. I will have a fine day and I can't figure out any rhyme or reason. And I'll suddenly be gasping for air like a fish out of water. And if I sit down, if I stand up, if I eat something, I can't find any reason for it to happen. I've tried to maybe exercise too. I have a little gym set up in my garage, so I'll get on the treadmill. But I noticed last week when I was on the treadmill, my blood pressure was 181. Excuse me, my pulse rate was 181. This can't be good. And I can't figure out how to stop it or control it.
Oh goodness. Yeah, you should definitely, well, first of all, shortness of breath could be so many things, and certainly something that our patients with PD do report. I always start with a cardiac workup, start with their PCP, send them to a cardiologist, do a pulmonary workup too. I make sure all those rocks are looked under, so to speak, just to make sure that we're not dealing with something with another totally different system, cardiopulmonary system. So thing is with Parkinson's too, all your muscles are stiff, but some people do feel this kind of stiffness around their intercostal muscles. The intercostals just don't expand the way they used to, and you could get the subjective shortness of breath. And I've had many patients that I send for a full cardiopulmonary workup, and it's completely benign. Pulmonary function tests are beautiful. They're fine. Sometimes they have a little restrictive disease because of the lack of expansion in Parkinson's disease, but just the chest wall. But more often than not, it could be due to Parkinson's. But always make sure that it's not something cardiopulmonary. God forbid. You just want to make sure.
I've been to three pulmonologists and my cardiologist and my neurologist, and no one can figure out what the issue is.
Oh wow!
One pulmonologist told me anxiety. I'm not any anxious any more than anybody else. I don't think.
I know Mac. Mac is a mouth breather. He breathes with his mouth open all the time.
I am a mouth breather.
And we think, right, Mac?
Yeah.
Right? So
I
we
am
were
a
going to
mouth
do
breather.
something about that.
Yeah. Well, and
With
also
ENT.
Yeah, ENT. And then also, yeah, definitely we do find that this is an issue with Parkinson's. I've seen so many patients that are subjectively short of breath, and I just make sure they roll out cardiopulmonary, ENT, like you said, and then it's just this, and they'll find that it correlates with their levodopa on and off too, which is really fascinating. Yeah. But even though it's technically a non-motor, so it's really interesting, but not treated by DBS though, I will say. Right. I am obliged to tell you that. Anyway.
It's not treated by DBS?
It's not. I would say it's not. All right, so I'm going to move on to DBS though. Okay. So who evaluates you for deep brain stimulation? Of course, neurologist, or where many people start. And your general neurologist evaluates you, sends you to a movement disorder neurologist like us. And then movement disorders usually sends you to a DBS neurologist like myself or my colleagues at Columbia, Dr. Quay. And from there, we send you to stereotactic neurosurgeon. What's a stereotactic neurosurgeon? So these are surgeons that specialize in operating on the deep structures of the brain using a frame. And that's where the term stereotactic came about in the 1930s, where they used a frame to use coordinates to get to the deep structures of the brain. And that includes deep brain stimulation and focused ultrasound. So you could also see a stereotactic neurosurgeon from the get-go, and they send you a DBS neurologist as well to do the workup. But usually it's the neurologist, then surgeon sort of pathway. That's what we follow at Columbia anyway, in many places in the city. So when do you know it's time to talk to your general neurologist or your movement disorder neurologist about a referral to a deep brain stimulation neurologist? So, you have to keep track of your symptoms. And here on this chart, this is just an example of medication chart, or it's like a side, like a schedule, if you will, like keeping track of your symptoms. Can I get a show of hands? Who keeps a schedule? Does anyone keep a schedule? Yeah, I think this is so important because this helps you communicate seamlessly with your neurologist, or at least it should. And I think when you track it, and you can state, I always tell my patients, your Parkinson's more than I do by a long shot. And I think it's important that you tell me about this. So, notice when you take your medication, whether it be carbidopa, levodopa, or even dopamine agonists like Mirapex or Carmapexol, make a note when you take it, when it starts to kick in, how many minutes or hours sometimes. And also if there's a dose failure where it never kicks in, really keep track of those dose failures and what time of day they happen and the correlation to the L-DOPA dosing. And when does it wear off? It starts to kick in, and it's beautifully working and, for an hour or two, and then it wears off. So keep an eye on those fluctuations with a chart like this. I find this very helpful. And then also, do you have side effects? When you take the levodopa, do I suddenly get dizzy? Do I have any changes in my blood pressure? Do I have nausea, vomiting, diarrhea, etc.? You just keep track of that. And if it correlates with a certain time of day, keep track of this. And when you talk to your neurologist, like, hey doc, I'm having less and less efficacy from my medication. It's just not working as well as it used to. It's not having a good peak dose, or I'm having X dose failures per day. Because what we could do with that information is it translates to them, well, you know what? Oral medications aren't cutting it. We have to think about other therapies, whether it be with electrical stimulation or, infusions or subcutaneous buttons, etc. So I find that these charts, as hokey as they might be, I think they actually are very helpful, and they help open the lines of communication. And, don't be afraid to speak up. If you feel like this is your story and it's not being heard, definitely don't be afraid to seek other opinions, or even find a DBS neurologist yourself, or a movement disorder specialist yourself. And they'll be the ones to be like, yeah, I don't think you're a good candidate, whether it be from a cognitive standpoint, or, your symptoms aren't fluctuating as much as we would like for them to be considered for a DBS or a secondary therapy. So I think it's really important to advocate for yourself. So what does DBS treat? Motor fluctuations, like I mentioned before, those ups and downs, tremor. It could be, usually tremor, especially the extremities, is best treated by DBS. The midline tremors, not as much, but we certainly have some benefit from that. Rigidity, slowness, dystonia. Dystonia is certainly treated by DBS, and dyskinesias in both the on and off states. So you have these biphasic dyskinesias, which could occur when you're wearing off of your medication, and also at the peak dose. So, write those down, keep track of those symptoms on your chart, and make sure you convey those to your provider.
Did you bring a chart for all of us?
I didn't. I'm happy to send one to you though, and you could send it out. Is that okay?
That would be great.
Okay. And I know I promised not a lot of words on a slide, but I think it's important to say that DBS and other advanced therapies don't treat non-motor symptoms. I know I'm really emphasizing this too much, but I think expectation setting is very important in the DBS and advanced therapies process. I always tell my patients I'm a terrible salesperson because I will tell you what it realistically treats, because I'd rather under promise and over deliver than the other way around, because I don't want to have you be disappointed in the end. I want you to know what you're getting into, and I want you to know all the adverse outcomes. I want you to know our stats. I want you to know that, it won't necessarily help your mood disorder, although DBS could treat depression, and I could get into that, but not when we treat for Parkinson's disease. I could go on and on for an hour about that, but I won't. Memory, it doesn't make it any better. Urinary constipation doesn't really help that. Dysautonomia symptoms like blood pressure fluctuations doesn't help that. Similarly, speech difficulty, slurring of speech, the dysarthria, that doesn't get better. If anything, it could potentially get a little worse with GBS. So these are all really important things to keep in mind and keep track of and discuss with your provider. If those are your top most bothersome symptoms, well, then we might want to think about other options for you. So, if you ever have a provider promise you that it could help all of these things, I would just be cautious. And also, it's really important for you to keep track of what are your 3 most bothersome symptoms, whether they're motor or non-motor. I always ask my patients at the end of my DBS sessions, like, what are your top, if I could grant you 3 wishes, what would that be? You write them down. I put them in my note even to make sure that I can address them. And I will tell you frankly if I can't. So that also helps me figure out with the neurosurgeon, where should we target for DBS? And I know you heard a wonderful talk about DBS from one of my colleagues at Sinai a couple of months ago. So I promise I wouldn't go too into the weeds with it, but we do approach different targets for DBS, but all these things, your story really helps steer our decision making. And I think that's the sort of communication pipeline that you want with your provider. And if you don't feel comfortable, it's okay to say something, make sure that you're heard, because it actually helps improve our patient outcomes and make you a happier patient and give you a better quality of life. So what goes into DBS screening? It's a very long process. At Columbia, it could take 3 months or more. At peak pandemic, it took 6 months. Now it's about 1 to 3 months. We like to take our time and mull around with the information that we have from you and the objective data that we get from your examination. So, I evaluate you, my colleague, Dr. Kimberly Quay, evaluates you, or one of our neurosurgical colleagues evaluates you. That's the first step. And then we examine you on the clinical off state when you've held your medications since midnight. And then again, after you take your meds, we calculate that percentage change in your Parkinson, the UPDRS that you do all the time when you see your doctors. We calculate that change. We look for a 30% improvement in that score because that correlates with improvement with DBS. Doesn't mean we won't do it if you don't, but it does help us know that there might be a better improvement for you. And we're very transparent about that. Of course, we get the MRI brain and neuropsychological testing. That takes about 3 hours, and it helps us know what's going on from a cognitive standpoint. Because if someone has significant cognitive issues from the get-go, it gives us pause because we want to make sure that we don't worsen those symptoms. A little bit of mild cognitive impairment, very common in Parkinson's, not a big deal. But at least we want to know what your baseline is, and we recheck it at 6 months after your surgery to make sure that there's no concerning changes. So this is the DBS device. This is the graphite lead that we use to implant deep into the structures of the brain, either the subthalamic nucleus or the globus pallidus. You don't need to remember those, but just know that there's 2 main targets that we go for in Parkinson's disease. And the battery is very small. It's very tiny, and it sits in your chest just like a pacemaker battery. And the leads go under the skin, down the head, behind the ear, and to the chest. And it's a tiny little battery, just like if you had a friend with a pacemaker, it looks just like that, probably smaller. They're very tiny nowadays. And we use those 4 little contacts at the end to modulate an electrical field. And this electrical field is called a volume of tissue activation, VTA. It's a big sphere of electricity that we shape and bend and mold to make sure that we can A, give you the most therapeutic benefit, and B, more importantly, that you're not having any side effects because, I always say brain tissue is high cost real estate. It's very small, tiny little portions of the brain that, of course, that electricity could affect other parts. We want to make sure that doesn't happen. So that's what DBS is. And the surgery occurs all in one day at Columbia University. We have you come in at 6 a.m. Surgery starts at 8. We put the frame placement on. It's a frame that's around the head, like right here. And basically, we use that frame to target very specifically, using brain imaging, where to go. And we also use electrical signals called microelectrode recording to let us know specifically where we're going as well, and to plan it within millimeters of our target. So we use all those things, plus your examination intraoperatively to let me know and the neurosurgeon know that we're in the right place and that you're having therapeutic benefit and that you're not having any side effects. And then the last phase is always under general anesthesia, and that's when we connect the battery to the IPG, the leads to the IPG or the battery. So that's DBS. Before I move on, are there any questions about DBS? I know that was a lot of information.
I think, what? Oh, does it help tripping?
No, that's a great question. So DBS and gait is a little bit of a controversial topic. I'll be totally frank with you, because sometimes it could worsen gait when we target specific targets. The freezing of gait, if you mean by tripping, your feet get stuck to the ground and you festinate like that. And yeah. So I would say that I would tread cautiously if that's the most bothersome symptom, because there is a theoretical risk that it could worsen. Again, I'm a terrible salesperson, but I'm very honest with my patients. But on the flip side, if your gait disturbances are because of stiffness, slowness, and it's just that the slowness and stiffness is getting in the way of your walking, it could improve that potentially, because it is limb stiffness and slowness, or sometimes tremor, that interfere with gait. So absolutely it could help. But the tripping from freezing of gait, I would say no. There are some studies that suggest that low frequency stimulation and ultra high frequency stim could actually improve freezing of gait. I say anecdotally and in an honest way, it's hit or miss. I always give it a go, but it doesn't always. I don't use it as I never promise freezing a gait improvement with DBS.
Do you know anything about the mechanical vibration, like an external mechanical
Like
vibration?
the Cala and the gloves. Yeah. Like we do refer people for that, right? Yeah, we do. Oh, wait, I don't, but no, we don't. I just want to like look at, because I don't think we offer that. No, but I'm aware of it. I mean, the studies are again hit or miss. I mean, it's interesting. I mean, I think that external mechanical stimulation has been shown to help with some of these symptoms, particularly freezing of gait. I mean, because a lot of freezing is cognitive in a way, right? Where, you get stuck because you need a visual, you're not processing a cue and you have a visual cue, you step over the line or you step over the crack or the seam in the tile, for example. So certainly something is worth a try, but I'm personally not as familiar with it.
I want.
Well, who is there another question? Oh, hold on.
Both sides of the brain or just one?
Yeah.
Did you hear me?
Is it
I
both
asked,
sides?
when the operation is done, is it to affect both sides of the brain?
Yep. So at our center, we do both. We do bilateral for both, unless it's the VIM, which is a part of the deep structure of the brain called the thalamus that we treat. We target for essential tremor. For Parkinson's disease, we target the subthalamic nucleus and globus pallidus, and we do bilateral. So we do one side, we increase the sedation, and then we go to the second side. We, we try to go after the first side that's the most bothersome to you first, in case, we have to stop the surgery. I've never seen this, but just in case, we want to make sure your most bothersome side is taken care of, but I've never seen it aborted, but anyway, that's how we usually reason in the OR. Some sites do staged, which is perfectly fine. There's nothing wrong with that. I know a couple of sites in the city that do one side, they have you come back in a few weeks and do the second side. Totally fine. There's no wrong way to do it. It's just that our center prefers to do it all in one day. Same with all the different surgeries, the battery, leads, everything in one day.
Thank you.
Yeah.
I have a question, remote.
There's someone from.
Oh, the Zoom. Hi.
Hi, question? Can I go ahead?
Yeah, go ahead. Yeah.
Yes, okay. My issue, I don't have any tremors. The only issues I have are the breathing issues, and I get downtime. I basically can't walk. So, but DBS would not be appropriate for me if those are the two issues I'm dealing with. Is that correct?
Yes, you said breathing issues, and the second one was what? I'm sorry, I didn't. Bothersome off time.
I get frozen foot. I can't walk.
That's freezing.
I think ambrosia helps. I think if I'm in a
yeah, that's a freeze.
Situation.
I would say no. The thing is, if it's purely just off time, I would say bothersome off time that's getting worse and worse and more lengthy and bothersome, I would say absolutely it could help it. But if it's a freeze, like freezing of gait and also the respiratory issues, I would say not likely to help those bothersome symptoms.
Those are the two issues I have.
Yeah.
Yeah, so, okay. Thank you.
Is this a proactive or reactive operation for surgery?
Oh, that's a great question. So the face of DBS is changing dramatically. I will say that it's becoming more and more proactive. It used to be very much so reactive. In my usually when I give this talk, I go into like the history of it and like how we used to wait 10 to 15 years or more is like a last ditch approach to treat motor complications of Parkinson's. But now we give it about 5 years. Some people give it 10. I personally give it 5 years to make sure that there's no bothersome red flag, no worrisome red flag signs associated with atypical Parkinsonism. But if you're having bothersome symptoms that are causing a worsening quality of life, we approach it more in a proactive fashion rather than reactive. With that being said, there's a lot of providers out there that do it more in a reactive sense, but that's sort of going to the wayside. It's becoming increasingly proactive. I hope that answers your question. I think that's what you're getting at. Yeah. Yes, maybe. But it's not a neuroprotective therapy, though. I want to make that abundantly clear. None of these are neuroprotective. These are, if that's what you mean by proactive, I mean, this doesn't help with the progression of PD. It just helps the symptoms that you have. Okay. I think we should move on to these because I don't want to waste, I don't want to suck up all the time. So other advanced therapies. So we have continuous versus on-demand therapies. And what do we mean by those two types of therapies? We have infusion therapy. So like I said before, in these advanced modalities of treatment, we're trying to follow these ons and offs and maybe just kinesias because you have a sudden burst of levodopa, etc. And we want to chase those. So infusion therapies are really a good way to have a steady continuous flow of L-DOPA in the case of this duopa infusion, where it goes through the small intestine and it provides 16 hours of infusion of L-DOPA in a gel form through the intestine throughout the day. It's on for 16 hours and off for the remainder of the day. So we calculate your day-to-day levodopa and we basically calculate an intestinal flow of this in a gel form to have you covered throughout the day. We also have a form of that also contains a Comtan, which is a additive medication to help extend the half-life. So it's another option that's a little bit newer than the original duopa. And also we have subcutaneous apomorphine infusion, where you have a dopamine agonist called apomorphine that's infused continuously. So these are all things that we could consider for someone who's maybe not a great candidate for DBS, whether it be a cognitive cognitive manifestation of Parkinson's or other reasons that you just don't want to get wires in your brain. So infusion therapies are a good option. On-demand therapies are also helpful for a rescue therapy. So what do we mean by rescue therapy? We mean you have a deep off. You really want to get out of the deep off where you can go about your day. It doesn't act very long. It just gets you out of a slump. That's the Inbrija, the L-DOPA inhaler. And there's also the sublingual film. There used to be the L-DOPA sublingual, which is Parcopa, which is no longer available, unfortunately. And then the apomorphine pen. So these are all things that are offered to help get you out of a deep off. That's what we mean by on demand. So this is just something brief that I'm going to go over for the duopa. This is just the cassette and something that we program to get the adequate dose to you in a continuous fashion. Again, it goes through the small intestine and it just bypasses a lot of the metabolism that goes on in the GI tract, and it helps more directly get you L-DOPA that you need. And the subcutaneous apomorphine is something that you just have infused into the subcutaneous tissue continuously that helps prevent deep bothersome offs and kind of more of a proactive sort of rather than reactive approach. So these continuous infusions are more of a proactive, and then the on-demand is more of like a reactive, to steal your words. I like that. That's a good way to think about it. And so just to talk about, when do we consider these, and when should you be talking to your doctor about these therapies, whether it be DBS or subcutaneous or infusion, etc. it's like if you have bothersome symptoms, again, look at that chart, and make sure that you could identify what bothers you the most. And if there are motor symptoms that are, bothersome that could be potentially treated with these other therapies, you should definitely talk to them about, or ask to talk to someone who could help you with that. We have, of course, the early preclinical or prodromal Parkinson's disease, and then we have the early stage of PD when we start to use the medications like L-DOPA or dopamine agonist. And then at this time, we're using oral or the dopamine agonist patches as well. They mentioned here transdermal patches for the first decade or so of the disease course. Then you start to develop motor complications, the wearing off and fluctuations, etc., and dyskinesias, like I mentioned before. And so this is when we start to think about more advanced PD therapies, whether it be infusion, DBS, or subcutaneous. So any questions about that? Okay. So for the sake of time, I'm just going to go through this. I know I promised I would be talking a bit about weight changes in Parkinson's disease, and I think this is a bit of a hot topic. And it's interesting. My background is in nutritional epidemiology, and my clinical practice is DBS. And I talked to my mentor one day. I'm like, well, how do I combine these interests? These are very disparate interests. Like, what do you do? Like, have you thought about doing weight and nutrition and DBS therapies? I'm like, well, that's really interesting. And it's hard to study, so that's why no one does it, I think. But I figure no one's done it, so I'm going to do it. So anyway, weight change is a huge problem in Parkinson's. And in fact, early weight loss we know is associated with poor outcomes in Parkinson's disease. It's increased frailty, increased morbidity and mortality. So, I always joke with my patients that I'm one of the few doctors who would tell you to gain weight. Or maintain your weight. Don't lose weight. Try not to lose weight if you can, because honestly, it could not be great. So the thing is, we see this in early motor PD. And in this chart here, you don't have to go through the whole thing, but you know that, hyposmia, the lack of sense of smell, changes in your sense of taste, and then also changes in your hypothalamic hormones, the ones that make you eat more, like orexin and ghrelin, they're affected, and then leptin, which also causes you to eat less, are all affected because of the parts of the brain affected by Parkinson's proximity to these hypothalamic nuclei, these parts of the brain that affect weight and metabolism. So these all happen very early on in pre-motor PD. And we know as the disease marches on and you have symptomatic Parkinson's disease, we start medication, L-DOPA, 20% of the time gives you nausea. So these things contribute to weight loss. And then as the disease goes to a more mid-stride to advanced PD, we have increase of dyskinesias, you have changes in your energy, resting energy state, you have more burn of calories, and then of course, rigidity, tremor, all these motor symptoms cause you to burn calories and you lose weight. And of course, in late stage, difficulty swallowing, impaired mastication or impaired chewing could also contribute as well. So weight change could certainly occur. But weight loss could certainly occur. But what about weight gain? Some patients, they're not as active as they used to be. And no matter how much they have tremor and dyskinesia, they do actually develop some weight gain because they're just more sedentary. There's, a change in their appetite. They have, maybe an increased desire to eat sweets. Sometimes it's interesting. So sometimes they do gain weight, but it's less frequent. And then after STN DBS surgery, because of where we're stimulating so close to the hypothalamus and the electrical sphere of the sphere of energy, I mentioned what we modulate to improve your symptoms could actually adversely affect pathways that cause you to become more impulsive, possibly, or sometimes apathetic. And people have changes in eating behaviors, which is really interesting and definitely not what the intended effect of DBS was. So certainly could occur. And, what we're working on now is trying to figure out how we could prevent that, because sometimes the weight gain can be very bothersome to the patient after they get DBS surgery. And we know it could be a variety of reasons between apathy, impulsivity, and of course, just changes in the brain metabolism and the hypothalamus, as I have here. I won't go through this for the sake of time, but do know it occurs. We also see sometimes people when they're started on dopamine agonists like Mirapax, morphine, Requip, you could have increases in impulsivity, and sometimes patients have a lot of change in appetite because of that. And you add that STN DBS treatment, you could certainly have a lot of weight gain. So, between that and the decrease in energy expenditure after we treat your motor symptoms with DBS, add medications onto it, we're going to have quite a bit of weight gain. So the classic energy intake and energy expenditure, there's imbalance, and that leads to sometimes weight loss, but a lot of times weight gain. So important to know that. So what can we do about it? Of course, exercise we know is the one thing we can all agree that helps with neuroprotection in Parkinson's disease. We know that it helps with the disease course. We know that dance exercise is very important. But we also know that certain diets are helpful as well. Like the Mind and Mediterranean diet. The Mind has lots of vegetables, green leafy vegetables, spinach, etc., berries and, fruit, beans, nuts, and one or more weekly servings of fish. And the Mediterranean diet has vegetables, fruit, legumes, nuts, and at least 3 servings of fish each week. So these are all both been associated with better outcomes in Parkinson's disease. It can help manage weight and also give you a lot of protein to add on muscle rather than fat mass, which is very important in Parkinson's disease. So anyway, we're doing a study now. We're just looking at mechanisms of weight gain after DBS, but we're also recruiting for healthy controls. And basically, we're doing calorimetry studies, imaging studies, and food diaries, and looking at micro and macronutrients of individuals with Parkinson's disease with and without DBS. So if there's anyone who's interested in that, please give us a call, let us know. Happy to help you out. It's a 1-year commitment, and we compensate for your time for sure. So we're definitely looking into all these unanswered questions. So just wanted to introduce you to the team. Dr. Quay, my colleague, also DBS neurologist, myself, Dr. Gordon Beltuck, Dr. Brett Youngerman, our wonderful neurosurgeons, Kristen Matulis, our fantastic nurse practitioner who keeps us all in line, and as well as the neurosurgery NPs, Anna and Maria, and then Lana, our wonderful administrative assistant. So thank you so much.
Thank you very much, Dr. O'Shea. We're going to hear from Dr. Akins now. One quick question.
Can you comment on the lexatenidide study in Toulouse?
Oh yeah, so exenatide. Yeah. So actually, I was involved with the Neurally study back when I was in Boston. Yeah. So yeah, it's a diabetic medication that they found was neuroprotective in rodent models, and this is the extended version of it. It's like a fancier version of exenatide.
But it's in patients.
I'm sorry?
It's in patients.
I know. Well, the Neurally study was in patients, and yes, I know. That's how it all started. It always starts with the rodents, right? But now it helped out with patients, obviously, in the Neurally study and exenatide, and they made this better tolerated diabetic medication similar to exenatide in the French group. So with good outcomes. Huh?
The human study at the University of Toulouse.
Yes. Yeah. It's the exenatide, sir.
Could you comment on your thoughts about that? Because it seems like it's a different pathway. And
yeah. No, I mean, I get this a lot because, so yeah, those GLP-1, all of these new medications for weight loss and diabetes, there's always this question, is it neuroprotective? The thing is, we have to be careful because we don't want to cause patients to lose more weight. Because again, that's poor outcomes in PD. But in the flip side, they've been finding that some of these have been quite neuroprotective. So I think with anything in life, it's all about balance, right? So, if you find that you're taking these medications like exenatide or a similar medication for neuroprotection, yeah. Yeah, no. Sorry, were you? Yeah, well, they need a bigger study, and it was a negative study, but
I know it's getting a little late here, so I would love to, Dr. Aiken. Thank you, Dr. O'Shea. It was a very excellent talk, really. Thank you.
All right, so I will close out here today. My name is Julian Egan-Liebes. I'm one of the neurologists at Columbia University. Thank you for staying here to the end. So today I'm going to talk about how research can empower those who have Parkinson's disease as well as their care partners. So I'd like to start off with a question for everybody. When you hear the word research, what comes to your minds? Any thoughts?
Groundbreaking ideas.
Heard groundbreaking ideas. What else? Sorry, I can't hear you in the back. Guinea pig. Okay. Anything, any other comments? I think those are all, valid comments. And I think, when I think of research, I see it as a way, at least for the community, to ask questions. I think one of the biggest questions is, why? Why do people get Parkinson's disease? Why do people have certain symptoms? Why does someone have tremor? Why does someone have freezing? What are better ways that we can treat Parkinson's disease? I also see it as a way to learn. Participants can learn more about their body, about themselves, their disease, and the scientific community, neurologists, care partners can learn about mechanisms of disease, as well as like symptoms that are important and meaningful to the patients. Obviously, big picture, we want to lead to changes in management. It's also a way to test new interventions. And that may be, probably the first thing that comes to mind are medications. But it could also be things like a specific exercise regimen, a mindfulness activity like meditation. It doesn't always have to be administering something pharmacologic. And so I like dividing research into two different types of buckets, those that are observational and those that are interventional. And so observational research is a way of answering a question by collecting information. That information may come in the form of a blood sample or a questionnaire, and sometimes even a lumbar puncture, which sounds kind of big and scary. But really these are, procedures, and why it's so important is that, the cerebrospinal fluid, which is the fluid that surrounds the brain, can really give us a lot of information to help better understand the disease. Then we have our interventional research, and these are studies that are answering a question by administering a new treatment. And that treatment, like I mentioned before, could be a medication, it could be a new device, maybe it could be, for a DBS, a new location. It could be even a behavioral change, a new exercise regimen. So there's really a wide scope of research and what it could be. And something that I really want to emphasize here, and it may sound kind of obvious, is that all research is voluntary. There should never be any pressure to do research. It is always separate from clinical care. And what happens in a research study will never go into the clinical chart or affect insurance prospects, whether it's your medical insurance, life insurance. And it's also good to understand that, the results of a research study may not always be shared with you, the participant. However, we do have one research study, and there are more, that where results are being shared, and there are clinical implications for that, and I will discuss that shortly. So why is research important? It can give this sense of empowerment. I don't need to tell many people in this room that, having Parkinson's disease is unique for each individual. It can be unpredictable, whether it's a sudden off, a fall, a freeze. One day you may feel like $1 million, the next day you really feel like just not yourself. And you're on a ride, it could be on a ride where you have no control over. And I see research as a way of having more agency in the disease. People with Parkinson's disease, as well as their care partners, can be a part of the path of the cure. Scientists, researchers, neurologists can't get to a cure without people who participate in research. Additionally, patient advisory groups are now commonplace in almost all research studies. So this is a way for patients or care partners to tell the scientific community what is important to them and have a role and be a stakeholder in what research studies are being done. I think this is a way to be proactive in your course. So I want to discuss a bit about a study where you can learn more about yourself. And so there's a study called PD generation. Has anyone in this room heard about this study? Okay. So this is a study that does genetic testing for Parkinson's disease. And so this is really trying to get it to answering the question of why do people develop Parkinson's disease and what's the cause? And so when we look at, why people develop it, we know that about 13% of people who have Parkinson's disease have a genetic mutation. And in certain ethnic groups, this can be higher, including those who are of Ashkenazi Jewish descent. And so this is a national study that is funded by the Parkinson's Foundation, and so far has recruited over 15,000 people who have Parkinson's disease, which is incredibly impressive. Up to this point, the testing was looking at 7 genes And there are two genes probably that are the most popular of these genes, one of them being GBA1, the other being LRRK2. And these probably account for the majority of people who have genetic forms of Parkinson's disease. And I think what's really unique about this study is that it's actually one of the few studies where results are being shared with patients. And maybe years in the infancy of this study and years before, you know, for genetics of Parkinson's disease, one would be like, well, what do I do with this? Now we have tangible routes for using this information. The first being precision medicine clinical trials. In the New York area, there are currently 2 clinical trials that are looking at specific genetic forms of Parkinson's disease. And I can say at Columbia, we have a clinical trial that is specific for those who have a GBA1 mutation. And it's a study that's funded by the BL pharmaceutical company. And there's also a clinical trial, unfortunately it's not at Columbia, but other institutions in the New York area also have a clinical trial that is specifically for people who have a LRRK2 mutation. Additionally, knowing this information can actually give a sense about the progression of the disease. We have studied and learned that different genetic types of Parkinson's disease may have a different course. So for example, those who have the GBA1 mutation, we have noticed and learned that cognitive impairment may be a more prevalent symptom than those who don't, which can be a bit of a hard pill to swallow. Being told that, you know, you have a genetic mutation that may increase your risk for cognitive impairment is really challenging. However, this doesn't apply to everyone that has this genetic mutation, and it allows for the person who has the genetic mutation as well as the family to plan and look ahead for the future. We also know that those who have the LRRK2 mutation tend to respond a little bit better to the medication carbidopa-levodopa or Sinemet. And so, you know, by looking at, you know, understanding more about why someone has a disease can allow us to kind of prognosticate a little bit what to expect and plan not just for the person who has the disease, but also for the family to understand the expectations as well. Another key implication is actually when it comes to deep brain stimulation. And so as Dr. Shea mentioned in her talk, neuropsychological testing is an important part of the deep brain stimulation evaluation because there is a risk for worsening cognitive impairment after the surgery. And for those who have the GBA1 mutation, there's been some studies that have shown that there's an acceleration of this cognitive impairment if you have this mutation. And I don't want to say that if you have a GBA1 mutation, this means you cannot get deep brain stimulation. However, is now another piece of information that is, you know, included and thought about when deciding on should we proceed with deep brain stimulation, which is, as Dr. Shea, is not something that we don't tread lightly with that at Columbia. It's a surgery, and it has, you know, really profound implications. And, you know, we try to collect all the information we can. And this is another piece of information that's very valuable. And so I also see research as not just having a benefit for the individual, but there's also a collective benefit. By participating in research, you're helping peers who also have Parkinson's disease, the scientific community, clinicians. We're all able to learn from this. And it's not just understanding now what's happening. For many research studies, information is saved, it's stored, we may go back to it and allow us to better understand and learn for the next generations of people who unfortunately will inevitably develop this disease. So if you're interested in participating in research, I recommend questions that you should ask as whether someone who has Parkinson's disease or a care partner. And I think the first question to ask of your neurologist is, do you have research studies? Not every neurology clinic does have research studies. I can say, you know, being at Columbia as an academic center that values research, we have several, but it's an important question to ask. And then I would also ask, are the studies observational or interventional? And that information can kind of help you decide. There's a different time commitment depending on which type of studies. And also, you should ask, what is needed of you? Is it a questionnaire that may take 15 minutes? You can even do it at home. Is it a blood draw? Is it a lumbar puncture? And I think you as the person participating need to decide what you're comfortable with and what you want to do and how much you want to be involved. And another key question is, will you get the results back? Many research studies do not share the results for a variety of reasons, but as I mentioned with the PD generation study, this is a study where the results are shared. And so I think that's important to know going into that, because you may participate and that may be the end of it. You may not hear more, or you may get information and that can have implications moving forward. And lastly, you should ask about compensation. Not all studies will compensate, but they may help, with transport to the clinic, or giving you a parking voucher, or you may even get cash compensation. So things to kind of think about and understand before participating in a study. And briefly, I just want to share, a few of the studies that we have at Columbia. I discussed the PD generation study, which is a national study. Columbia is a site where we do it that does genetic testing for Parkinson's disease. We also have the BL clinical trial, which is for people who have GBA1 mutations in Parkinson's disease. We also have studies looking at what we call biomarkers for Parkinson's disease. So a biomarker is a marker, whether it may be in blood or other body fluids, to better understand if there are certain markers that we can find that it can help us diagnose, track progression. I would say kind of a more quantitative sense of the disease. As probably many of you know, the diagnosis of Parkinson's disease is very much a clinical diagnosis. And so we're trying to get other testing that may help us to help with the diagnosis and also track progression. And then as we find new therapies, ways of knowing, are these therapies working? And so we have a couple of studies at Columbia trying to better understand how the immune system may play a role in Parkinson's disease. And so I am the principal investigator of a study that's funded by the Michael J. Fox Foundation that collaborates with neuroscientists across the world to try to better understand, could there be an inflammatory component to Parkinson's disease? And so we're looking for people who have Parkinson's disease, certain genetic forms of Parkinson's disease, including the GBA mutation and LRRK2, as well as controls, which are, people who do not have Parkinson's disease. We also have an interventional study looking at presumed gait that my colleague, Dr. Quay, has, which is trying to better find a treatment for this symptom that unfortunately carbidopa-levodopa doesn't always treat so well. And so she has a study looking at a spinal cord stimulator, where it's like a small device that's put in the back and seeing if this could help improve the symptom. Dr. O'Shea talked about how she has a study to better understanding looking at the metabolic function in Parkinson's disease and those who have DBS. And in the future, we're going to have cell-based therapies looking at stem cells and how that can play a role in improving Parkinson's symptoms. And preliminary data has shown promising results. And it sounds like science fiction, but this is actually could be probably a new treatment in the years ahead. I also want to highlight the interdepartmental and interdisciplinary nature of our division, and we work closely with our colleagues at Teachers College within the speech pathology department as well as physical therapy department. And one of the studies that is ongoing is a study with Dr. Michelle Trochet, who's a speech pathologist, who really wants to better understand cough and swallow dysfunction in those who have Parkinson's disease. So this is a study where she's trying to test two different types of tools to better assess cough. It's a study where you can receive compensation, and there's also a free swallow evaluation involved in it. Another study I want to profile is another colleague in that department by Dr. Moya Gallet, who is also a speech pathologist. She's been trying to understand how Parkinson's disease affects women, and also looking at certain aspects such as social connectedness, physical activity, and cardiovascular health in those who have PD, Parkinson's disease, as well as those who do not. So to kind of summarize here, I hope I've shown you or just, impressed on you how empowering participating in research can be. There are several different types of research opportunities, and I think you need to decide what is your comfort level and how much research you want to do. There's no right or wrong here. And I think it's a really important mechanism to learn more about the disease, about yourself, and there's now clinical implications, especially when it comes to genetics. I would say, I think one of the more exciting new therapies that are going to probably come up next are these precision genetic-based therapies. And I think for those who are interested, genetic testing will open doors to these new potential treatments. And lastly, I think, it's important to know that, Parkinson's disease is a very tough disease to study and treat just because it's so different for many different people. And, in our lifetimes, we may not come up with a cure. I am confident we're going to make a lot of strides, but by participating in research now, you're not just helping yourselves, but generations of people who are inevitably going to develop this disease themselves. So this time, if for anyone who's interested in participating in research, I have up here, there's an email address that you can reach out to. It's neuropdresearch@cumc.columbia.edu. This goes to an inbox that will be shared with other research coordinators and can direct you to the right person. And I'm also happy to take questions now.
So you do not need to be a patient at Columbia to do your research.
No,
Anybody can.
Anyone can reach out. Yes, I
Thank
see your
you very
question back there.
much.
I think we're gonna get a mic for you.
I think I did do that PD gene one with, I think Indiana University.
Yes, so the Indiana University is the kind of the main
Yes,
site for
it's
this.
really fun. I mean, I don't know, somebody here, I think, mentioned it and a bunch of us did it.
Oh, that's great. I'm really happy to hear that.
They just had us spit in a cup and send it back, but they did actually send us the results, which I shared. I didn't come back to have anything. And the only one I know that Ozzy Osbourne says he has one of the genes. I forget which one he said, but I've seen it in print. And then I also do the one thing with the Michael J. Fox.
Oh, yeah.
They won't let you in if you've already started the carbidopa levodopa. So I didn't know, and I think that's something for you when you're diagnosing in there to tell people to do the baseline before. And so instead, they just have me answering questions every few months.
Yeah, I could speak to the PPMI. I'm the PI for PPMI, Michael J. Fox study. You're correct. So we're looking for de novo patients, people who've been diagnosed within 2 years now. It used to be 3 or 5. It used to be longer, but now it's very new de novo patients, levodopa naive. With that being said, though, if you start medication after you've been recruited, it's perfectly fine. You just have to let us know. But we're looking for de novo within 2 years.
Yeah, I was a bit disappointed because I went to the Michael J. Fox seminar in New Jersey like a week after I'd started taking it. So it was, it wasn't mentioned to me at Columbia when I first saw my MDS there. So it just might be something you might want to talk about between the staff, the doctors. And the other thing I just want to say, you probably get a kick out of is I was originally diagnosed by a doctor at Mount Kisco Medical Group. And he sent me in for some testing at Columbia. And when I went back to see him, he says, okay, I'm turning you over to Columbia now. He said, because when this gets worse, he goes, they've got studies and they've got clinical trials and I've got nothing. So I'm going to send you to them. So I just thought you'd like to hear that.
Thank you for sharing.
I want to thank you, doctors. This has been so wonderful.
I think I see one more question.
Oh, Hope. Okay.
Thanks. We're running one more time. Just a quick question, and forgive me if I've missed something here. Is there any work being done with prevention and or different choices? Like, is there a fork in the road, where let's say a beginning symptom shows up and it's very mild, and then you're like, okay, we got to go in this direction now? Or
That's a great question. I think it's something that we're all trying to better understand, and it's very challenging. We're trying to find, what are symptoms that may happen before someone develops motor symptoms of Parkinson's disease. One disorder called REM sleep behavior disorder, rapid eye movement behavior disorder, is a condition that there's a lot of interest and better understanding because many people who have that may develop Parkinson's disease, and as a way of maybe keeping it at that sleep disorder and not developing the symptoms. I think something that maybe was alluded to today is the benefit of exercise. And we know that, that's what we know is the only disease modifying intervention we have. And I think there's some data showing that, people who stay active may be less likely to develop, but unfortunately it's hard to know because probably what's causing Parkinson's disease is many different mechanisms. So I don't think it's like a one size fits all. So unfortunately, I don't have a great answer to that, but I would like to have that.